So we've just finished up the lecture on membrane potential and action potentials. Let's do a challenge question to see if you understand the concepts. So we've talked a lot about the role of sodium and potassium in neurotransmission, or the propagation of electrical signaling in neurons. Here we're going to talk about low and high potassium and how that affects neurotransmission. So hypokalemia, or low potassium, is a common reason for hospital admission. It can result from diuretics, severe diarrhea, vomiting, and other conditions. Hyperkalemia, or high potassium in the blood, is seen in patients with kidney failure, particularly elderly patients, patients with metabolic acidosis, patients taking ACE inhibitors or potassium-sparing diuretics. Both, however, hypokalemia and hyperkalemia can lead to dysfunction of the muscle or muscle weakness and fatigue. How does this happen that both low potassium and high potassium can cause muscle weakness? Of course, they each have a range of other symptoms as well, but let's think about the muscle weakness related to potassium. So think about, what is the role of potassium in the membrane potential and the action potential? How would an altered potassium gradient affect the membrane potential and the action potential? Let's graph this and take a look. So what we know is that the equilibrium potential for potassium is somewhere around minus 90 millivolts, and that our resting potential for any given neuron is around minus 80 millivolts. So our normal resting potential is going to be sitting at minus 80 millivolts. We also know that potassium is involved in the falling phase of the action potential and the after hyperpolarization of the action potential. But first, let's look at the effects on resting membrane potential. If you have a cell where the outside of the membrane compared to the inside of the membrane normally would be about minus 80 or negative because of the potassium leak, then all of a sudden you reduce the amount of potassium that's in the blood. That's a hypokalemia. How would the membrane potential respond? Well, if you reduce the amount of potassium that's outside the cell, what you're doing is actually increasing the potassium gradient, meaning that the difference from the inside to the outside of the cell suddenly just got bigger. If you have a larger potassium electrochemical gradient, you're going to have a larger change in the negativity of the membrane. That means that your resting potential for hypokalemia or low potassium is going to be lower than normal or more negative. What about the opposite? What if instead you add more potassium to the outside of the cell? Well, now you have decreased your potassium gradient, effectively decreasing the pull on potassium outside of the cell. Well, if you decrease the potassium gradient, that's actually going to depolarize the resting membrane potential to a less negative state. So this is going to be a hyperkalemia. which is going to depolarize the resting membrane potential. And that's in a high blood potassium condition. If the cell membrane is depolarized, it's effectively closer to threshold and more excitable. That means you can reach threshold more quickly, leading to an action potential. But it also means that you don't hyperpolarize or get as negative as you normally would. If you don't hyperpolarize to the normal level, or the cell membrane is too depolarized, you can't reset the voltage-gated sodium channels. And what that's going to do is maintain the voltage-gated sodium channels in their inactive state. That means the next time you try to generate an action potential, you're stuck because your sodium channels haven't reset, and you can't have anything happen after threshold because the sodium channels are plugged. So in both cases, you're going to have difficulty getting action potentials. In the case of hypokalemia, it's because you're too far from threshold to generate enough stimulus to get to threshold. In the case of hyperkalemia, you may have a depolarized membrane potential, or you may be closer to threshold, but it's not only excitability, it's actually the resetting of the sodium channels that's required. And without resetting those sodium channels in that after or repolarization phase, you can't get any further action potentials, meaning that it's also going to be difficult to get action potentials in a hyperkalemia state. So in either case, your ability to generate action potentials is going to go down, and you will have muscle weakness. If I spoke a little too fast, here's a summary of what I just said. In hypokalemia, the low potassium in the extracellular fluid will lead to a more hyperpolarized membrane potential, making it more difficult to reach threshold and get action potentials to those target cells, to those muscle cells. In the high potassium or hyperkalemia, it will lead to a more depolarized membrane potential, but you can't reset those sodium channels, and that means in the next time you try to get an action potential, it'll be much more difficult because you don't have as many sodium channels ready and waiting to hit threshold and to depolarize the action potential. So in both cases, you get less muscle contraction and weakness of the muscles. All right, I hope this was helpful. Please let me know if you have any questions, and I'll see you soon.